What's up? Doc Mike. Public Health on Call. By Johns Hopkins Bloomberg School of Public Health. Today's topic for November 3, 2020. How COVID-19 is impacting sex workers and people who use drugs. Thank you, Johns Hopkins Bloomberg School of Public Health.
Welcome to Public Health on Call, a new podcast from the Johns Hopkins Bloomberg School of Public Health. Our focus is the novel coronavirus. I'm Josh Sharfstein, a faculty member at Johns Hopkins and also a former secretary of Maryland's Health Department. Our goal with this podcast is to bring evidence and experts to help you understand today's news about the novel coronavirus and what it means for tomorrow. If you have questions, you can email them to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Today, Colleen Berry speaks with Susan Sherman, a professor at the Johns Hopkins Bloomberg School of Public Health. They discuss what harm reduction looks like during a pandemic. Let's listen.
Susan, you've dedicated your career at Johns Hopkins to supporting the most marginalized people in our society, including sex workers and people who use drugs. What are some of the ways the COVID-19 pandemic is posing serious challenges for the individuals you work with?
Thanks for asking that question and caring about these populations. I think COVID impacts all of us, and for people that are less resourced in terms of housing and food, and if you have, you're earning your income from working on the street, it is just multiplied exponentially. So I think the way that it's impacting, if you think about people, women who sell sex, there's a lot less discretionary funding for people to buy sex. So women might be more willing to engage in higher risk behavior for the same or less money because they're earning less. I think that people really have to compromise their safety in terms of COVID safety because they may not be able to not crowd if they're buying drugs or if they're marginally housed. So many people that I work with are marginally housed or homeless, and they don't really have the luxury of not crowding. People don't have other forms of transportation except for buses to go and get food. So, and apparently in Baltimore City, for example, the buses are so crowded. So I think that the impact is just really magnified in people with less resources, and even more so if you have a drug addiction because of what you need to do to procure your drugs.
So we know that not everyone is ready to seek drug treatment. And it seems like essential to this conversation is the philosophy of harm reduction. What does it mean to practice harm reduction in a pandemic?
Well, harm reduction in a non-pandemic or pandemic is really what we're all trying to do. It's reducing the harms associated. In the case of drug use, it's with bad policies, with bad drugs, with the illegality of drugs. It's not about bad people, but it's about the environment that can increase harm. So, and that's what we're all trying to do with mitigating our exposure to COVID. So I think that, practicing harm reduction in this pandemic, it's really doing the best that you can, even if everyone knows they can't eliminate their risk of exposure to COVID. And in many ways, I think this pandemic allows us an opportunity to be empathetic towards, all right, maybe I actually still need to go out to the grocery store or ride a bus because I don't have a car, but I'm going to do the best that I can do. That's not about drug use. That's just about getting by during this time when some people might not be able to totally eliminate risk. So in some ways, I think harm reduction is a perfect philosophy for everyone in this pandemic, and perhaps that would give people more compassion about how people who have addiction, who maybe aren't ready to go into drug treatment, they also need to reduce harm in their own lives. That doesn't mean that they eliminate all drug use, for example. Does that make sense?
Yeah, that's so interesting, that parallel, but it's harder now to support people. So for example, you, I know, founded the Spark Center for Women in Baltimore. So the majority of women at your center are engaged in sex work, and you offer services like showers, like drug treatment, like legal services. And I know your center has a food pantry, and you offer yoga and a chance to socialize. But I think it's true that you have had to close down your center. Is that right? And what's the implication?
Right. So we have closed down the center, but we are doing outreach once a week. And what we're doing, like other organizations in Baltimore, including Charm City Care Connection and the Baltimore Harm Reduction Coalition, we're doing drop offs. We do drop offs. We have a Google number that people can call. They call us when we do outreach. We have a van that we do mobile outreach. We're no longer doing that. Our center is not open for all the services you mentioned, that people call that number. Last week, we did 40 drop offs of bags that included syringes, Ensure, ramen, safer sex materials, masks, hand sanitizer, et cetera. So we are, and the City Needle Exchange program is still operating, but has cut their services somewhat. So we are, and these other nonprofits I mentioned, feel that it's really important to meet the needs of people through things like providing services in a way that's safe. So it's horrible. I mean, we know, and we actually are really excited that some of the calls we had last week, 10% were from people that never had engaged with Spark. We'll do drop offs to anyone that calls us. But you're right, it's really hard. A lot of nonprofits, organizations are around the country, harm reduction organizations are doing either having a table where people stand 6 feet away to get services, or are doing these kinds of drop offs, particularly when a lot of health departments are reducing their services to these populations, even though in some states these services are considered mandatory. They still are cutting them down. And nonprofits like Spark are trying to pick up the slack as much as possible. We also, just to say, another service we provided the health department used, because we work in partnership with the Baltimore Health Department, we went out with a nurse, a health department nurse, to provide hepatitis A vaccines, because there have been hepatitis A outbreaks in homeless encampments in certain parts of Baltimore. I just saw that there were 4 more people that tested positive today, and we're going to go back out a second time this week to provide Hep A vaccines. So we are still providing services, but nothing compared to what we provided previously. But we are doing the best that we can, because we still want to reach people in a safe way. My number one concern is the safety of my staff, so in the safest way possible.
So it sounds like services have been interrupted. The way we provide services has changed, and this is meaningfully affecting the populations you work with. Can you say something about the drug supply? Has the drug supply been interrupted? Do you have a sense of that?
So, in some cities, I've heard that that is the case. It hasn't been the case here, which, for better or for worse, because then people congregate to buy drugs and use drugs. But apparently, the drug market has not been that reduced in Baltimore City. Although it's hard for me to imagine that that will continue to be true. We know that methamphetamine, which isn't in Baltimore, but in other cities, comes through Mexico, and fentanyl generally mostly comes through China. Wuhan province was a big supplier, and obviously, trade from Wuhan when there was a shutdown was reduced, and also trade from China in general. So it'll be interesting over time how different jurisdictions are affected and impacted. I think the fact that we aren't experiencing decreases, but other locations are, really goes to show that drug markets, even though they're internationally sourced, the roots might be kind of location specific, where there's variety.
So you've made the statement, when dealing with the agony of physical withdrawal, social distancing is the least of a person's worries. And you sort of alluded to that a couple of minutes ago. Can you say a little bit more about that?
Well, I think that, in the kind of calculus of people's sense of their own risk in the moment when apparently withdrawal from opioids is one of the most painful things that people ever experience, more than childbirth. You talk to women who use drugs, and withdrawal is more painful than childbirth. And for those who've had children and experience some of that pain, that's pretty painful. When you're going through physical withdrawal, you are sweating, you're throwing up, you have chills. It's kind of like the flu. And it comes on pretty quickly, and it lasts a long time. So in the moment, people are going to prioritize abating those symptoms compared to something that might make them sick, that is out there, and not necessarily out there in front of them. But I will say, we've talked to a lot of women in our studies and who come to Spark because we're reaching out to people through a survey, and people are scared. So people are making, choices about going through withdrawal or their exposure to COVID. That's something that people actually are actively thinking about. So it's not like, I just don't want it to be perceived that everybody who is addicted to opioids is prioritizing their addiction over being exposed to COVID. I think it's complicated and it's challenging.
That's totally fair. So many people, though, have a visceral reaction to the idea that sex work and drug users deserve practical supports in their lives. That's a lot of what you've been talking about. Does living through COVID make these negative attitudes worse? What I hear you saying is it makes the experience of these individuals much worse. But do we have more extreme stigma in a moment like the one we're living in?
Well, one thing is, I think people don't even think about people living at the margins, whether they be using drugs or homeless, or I don't think people necessarily think about those folks. But when they do, I think and one thing that's been in the media around these kinds of populations is, humane policies for releasing prisoners. I mean, it's incredible. Prisoners who have less than 1 year left or are in for low level offenses. The fact that prisons are absolute incubators for this disease, and it's shown up in several states already where prisoners have been tested, let alone places where prisoners haven't been tested. And I speak about prisoners because I think that's been the most prevalent of thinking about the populations that I work with, many of whom have been incarcerated, arrested. That's the population, the prison population is kind of the closest to these folks. And, we are as good as our policies towards these people. And a disease like this brings us closer to people at the margins than ever before. They work in our yards. They are married to or are the people that are bringing our groceries, bringing Amazon deliveries. I mean, we are not physically distant from people who are marginalized, use drugs, sell sex, just got released from prison. And we physically are potentially compromised if their risk of COVID isn't reduced as much as ours. Does that make sense?
Absolutely. So there's a self-interest component to this as part of what you're saying in the context of an infectious disease. But also, I think, is it fair to say that this crisis tests our public policies, but even more fundamentally, it tests our humanity?
I mean, I would say that I think having that broad lens and thinking about the big tent and understanding that what happens to people that are incarcerated actually could impact you by the routes that I mentioned. The fact that folks could be coming in contact with you working at groceries or delivering your food or delivering Amazon deliveries or, however else. I hope that in general, people really have a sense of compassion for all different kinds of people and not just are self-interested, because self-interest really can be redefined by an epidemic like this. I mean, it is unprecedented to think of as something that spreads as easily as the flu is happening right now. And there's nothing that connects the dots more than something like this. So I hope that we as humans, it's just so scary to read, like the polarization that even this can have on people's notion of what to do and what is right and who deserves what in an epidemic like this. We are all connected and we are really literally as healthy as the sum of our societal parts.
So this brings me back to the philosophy of harm reduction that we were talking about before. Your career has been focused around working to meet the health needs of very marginalized groups critically with dignity and respect. What are those principles of dignity and respect? Why are they so important generally? And it sounds like you would say that they're even more important at a moment like this one.
I think it's really for all the reasons that I've mentioned. It just astounds me the connectedness that this kind of epidemic brings into light that maybe was in the shadows for some people, that people don't think that we are the fabric that we as a society have with one another. And, it's how I heard the lieutenant governor of Texas made a comment that, like, they, in the spirit of talking about reopening, that maybe older people will have to sacrifice themselves. And I mean, that's just insane. Are you willing to sacrifice your mother? Are we really willing to sacrifice members of our own society? Is this what we've come to? I think that this notion of valuing all humans because of not just that it impacts us, but because of their own humanity, that which taps into that notion that people need to be treated with dignity and respect, literally in a Darwinistic way, will help ensure the survival of our species. And, that's the notion of we are connected by a fabric of, like a very dense fabric. We are all connected. And I think that one of the ways that we survive is through treating people with dignity, respect, and making sure that they have access to basic services, and as best as they can socially distance, and that people in homeless shelters are as best possible able to be safe and stay safe. I mentioned earlier an organization run by a wonderful woman named Natanya Rabinowitz, who graduated from the Bloomberg School, called the Charm City Care Connection. It was started by Hopkins medical students. And she has, through state funding, placed 36 people as of today. I talked to her today, 36 people who use drugs who are marginally housed in motels. Wouldn't she repurpose some of her funding with approval from the state to do that? Why isn't the city doing that? Why aren't we putting poor people who are marginally housed into cheap motels? Because honestly, it costs a lot less. That costs a lot less than treating people in a hospital. So that's like a great example of treating people with dignity and respect, and also costs less to society and potentially spreads less disease if that's what you care about.
Susan, thank you very much for joining me today.
Thanks for having me.
Thank you for listening to Public Health on Call, a new podcast from the Johns Hopkins Bloomberg School of Public Health. Please send questions to be covered in future podcasts to publichealthquestion@jhu.edu. This podcast is produced by Josh Sharfstein, Lindsay Smith-Rogers, and Lamare Morales. Audio production by Niall Owen McCusker and Spencer Greer, with support from Chip Hickey. Distribution by Nick Moran. Thank you for listening.